Welcome to Etymologies of Care, a podcast about how language, awareness, culture, and relationship shape the way we exist in the world. I'm Paul Lichtenberg, and after more than 30 years as a clinical psychologist, I've learned that the most powerful changes occur not in isolation, but in meaningful, authentic relationships and how we think and express them. Here, we explore different ways of understanding and practicing care, from nervous system regulation to emotional development, to generating positive core beliefs, to spiritual fulfillment, to the power of authentic relating and community. Our hope is not to give you answers or solve seemingly incommensurate problems, but to spark curiosity in conversations that elevate awareness to help us all see ourselves and each other more clearly, more carefully. So let's begin. Hi, everyone, and welcome to Etymologies of Care. I'm Paul Lichtenberg, and today we're exploring something profound: how the words spoken in medical appointments can either empower or diminish patients in ways that directly affect healing outcomes. When we first reached out to today's guest about joining us for a conversation on applied linguistics and integrative relational health, something remarkable happened. We were taken aback in the most positive ways by her pure humanity, openness, and excitement about potential collaboration. We immediately felt a kind of kinship in our shared purpose without even having met. This speaks to that liminal aspect of language communication, even synchronicity, that comes as a felt sense of familiarity. Though familiarity here must be understood at its deepest levels of consciousness. Sometimes the most meaningful connections happen before formal introduction, when shared commitment to healing and understanding creates instant field recognition. I'm sure you've all experienced these moments in your lives. Maybe you've met someone at a conference and within minutes felt like you'd known them for years, or started reading a book that perfectly articulated something you'd been thinking but couldn't express, or walked into a space and immediately felt, this is where I belong. This connects directly to what we're exploring today, how language in medical settings actually shapes patient experience and reality itself, and how certain ways of communicating can create immediate trust and collaborative possibility. Today's guest is Allie King, a doctor of applied linguistics, scholar, and acting program director at Columbia University's Teacher College. She brings a unique focus on conversation analysis, and her personal health journey has completely transformed how she understands patient-doctor communication. Recordings of Allie's medical appointments during her battle with breast cancer would become both a survival tool to remember crucial information and an unexpected inspiration for research that revealed profound insights about healthcare interactions. We are honored to have the opportunity to explore this pivotal moment in your life, Allie, this intersection of academic expertise and lived experience, simultaneously experiencing medical care as patient, while maintaining a researcher's eye for the nuances of conversation that can either empower or diminish a person in their most challenging and vulnerable moments. We're hoping through this conversation to explore how language used in medical settings, healthcare contexts in general, and I would say in all relational fields, actually shapes our deepest experiences and reality. Allie, welcome to the podcast.
Hi, Paul. Thank you.
Okay, so let's start with the fun question. What do you think about our title, Etymologies of Care?
I love it. First, I'm fascinated by etymology. For me, understanding the origin of words and expressions helps me realize their power, part of which comes from the history and culture that's embedded in them. I remember being relatively young and learning that the word hysterical comes from the Greek word for uterus or womb. That discovery helped me see how language is never really neutral.
Yeah.
Even a single word can carry within it centuries of assumptions about gender, emotion, or authority. So we need to pay attention to the cultural legacies that can be implicit in everyday speech. I especially appreciate the idea of extending the lens of etymology to the notion of care, because it gets at something that we don't usually examine: how the language of care itself has been constructed over time. Words like patient and treatment carry histories that shape what becomes possible in healthcare relationships before we even start talking. When you really reflect, you see how much of language is actually shaped by rigid binary thinking that is very much wrapped up in hierarchy and power dynamics. The etymological approach offers something unique because it works at the foundational level, where reality gets constructed through language. When you excavate how words like care or anxiety have been shaped to serve binary thinking, you're providing tools for people to recognize and reconstruct their own meaning-making process.
Mm, beautiful, beautiful. We speak a lot about binary thinking at IRH. From a survival perspective, binary thinking evolved as a rapid threat assessment system. However, when this survival mechanism gets applied to complex social realities, it creates artificial categories that then potentially become tools and even weapons for organizing power, as we can readily see. The hierarchy is built into the structure because once you establish a binary, one side invariably gets valued, the other diminished, and worse, dehumanized. And those who control the definitions of binary categories control social organization. So, can
Mhm.
you talk a little bit about what conversation analysis is and what the focus of your work has been?
Sure. Conversation analysis, or CA for short, is an empirical way to look at how people do things with language in interaction. We transcribe interaction from video or audio data, and then we analyze both the talk and the nonverbal behavior together at the most detailed level possible. This helps us to identify the mechanisms people use to create meaning and to accomplish action while interacting with each other. We look at things like turn taking, repair sequences, how understanding gets negotiated in real time, and so on. Through both my master's and my doctorate, I studied co-teaching, or the arrangement of two teachers teaching together at the same time. I spent years examining this type of collaboration on an interactional level. I first became interested in this topic when I had two doctoral student teachers for a course during my master's. While I was impressed with the mechanics I was witnessing, like how they finished each other's sentences or supplemented each other's explanations to improve the instruction, I realized a lot of my fascination actually came from watching a professional relationship unfold right in front of my eyes. As someone who wanted to do the same program as these doctoral teachers, I wondered how I would feel or perform sharing the teaching floor with someone else. I could also tell, as a student, that this collaboration was bringing more to the table than what a single teacher could do alone. But it was just a sense. So I decided to study it. And listeners can read my dissertation if they want to, but I can give away one of the major findings, which is that, yes, the collaborative nature of co-teacher talk in the classroom can definitely contribute some unique and pedagogically advantageous things that just aren't possible in a solo teacher arrangement. But despite all the years of formal training and research in institutional interaction, perhaps the biggest thing that really worked to bridge the gap between theory and practice for me was actually a major disruption in my studies when I suddenly had to do a year of cancer treatment during the last leg of writing my dissertation. The experience of being both a researcher of interaction and a patient at the same time made me realize somewhat drastically how crucial each moment of interaction is in a medical setting like I was in. That experience shifted both my academic interests as well as my goals in studying interaction.
Wow. That is a powerful insight right there. Um, you said you realized that a lot of your fascination came from watching a professional relationship unfolding right in front of your eyes, including and especially when faced with cancer and medical professionals. In other words, if I understand this, you connected your own subjectivity, your own internal experience to bridging the gap between theory and practice,
Absolutely.
between
Yes.
theory and relationship. So, how can understanding conversation analysis transform how we show up in our most important relationships?
I love this question. When I first encountered CA as a master's student, I had no idea how my training in this theory and methodology would literally change how I experienced the world, and especially how I experienced interacting with others. Conversation analysis gives me the tools to pinpoint things like exactly where communication breaks down or where confusion is caused. In truth, we all are proficient in and use these tools subconsciously. Everyone with interactional competence relies on them. But having CA as a tool helps me make them visible and describable. That awareness helps me to recognize and
Mm,
change my own patterns and even helps me to have harder conversations with
mm,
others.
totally, totally. So, walk us through what your world was like during that season of 2023 when you were delivered this diagnosis.
Yeah. Well, so I was diagnosed with breast cancer in August 2023. Actually, my story is somewhat of a cautionary tale. In spring of 2022, I thought something felt off during my breast exam. And so I was sent for a mammogram and an ultrasound, and I was given the all clear. Fast forward a year, and you could see a lump in my breast through my shirt. My gynecologist agreed that it seemed concerning. So I once again went for a mammogram and ultrasound. During that process, I was so petrified that my legs were shaking. I told the tech that my mother had had breast cancer. The tech was kind and supportive. After the images were done, she came out and handed me the all clear paperwork and said to me, "It's just a cyst." I remember that word just standing out and holding so much relief, like it's no big deal. So even though I had been completely convinced before those scans that I had breast cancer based on what I could see with my own eyes, I took the professional's words to heart. I was about to continue with my busy life. So my unsolicited advice here is to push for more tests if you feel like something isn't right.
Yeah.
I'm so lucky that my gynecologist was not convinced by those scans because she pushed for a biopsy. A few days after that procedure, I got an email from the portal saying that my results were available. So I
Hmm.
opened it thinking it was going to be a case closed kind of thing.
Totally. Yeah.
So that's how I found out I had cancer while I was in the laundromat at 7 a.m. A month later, just before I was ready to start treatment, my mother died unexpectedly. And my dad, who had been diagnosed with Parkinson's years before this, didn't want to leave the state of Virginia where they lived. So my siblings and I moved him into a facility, and I ended up in charge of most of his life from afar. So there I was, single, trying to finish my doctorate, and
Hmm.
suddenly I was a caretaker and navigating cancer treatment pretty much alone.
So, Allie, the idea that there's nothing wrong with you as a human person, even when your body needs medical attention, how does that land with you? Hmm.
As a woman who is not only neurodivergent, but who's also struggled with mental health challenges her entire life, I am acutely aware of the feeling or the implication that there is something wrong with me. With respect to medical things, I have seen firsthand how when you have different diagnoses, whether it be breast cancer or mental illness, there are a lot of forces in our society that seem to push you to become this thing.
Mm-hmm.
It's not only because of how these experiences impact your daily life, it's that the world, including the medical authorities you're working with, frames it that way. The typical medical model locates problems within the patients. You
Hmm.
have cancer, you're non-compliant, you're anxious. So I really appreciate the effort to reframe this. I was dealing with cancer. I experience anxiety. My brain works differently than many, but I am not these labels. And there's nothing wrong with me as a human because of these traits or situations. Ironically, though, in my particular cancer journey, I have to say that some parts of the experience actually made me feel more valuable as a human, which I would say is in contrast to the idea of there being something wrong with me. I participated in a huge medical trial as well as another research study on the use of a post surgical medication dispensing device.
Hmm. Hmm.
So, not only did getting to participate in this research really fire up my nerdiness, but I got to frame my illness and treatment as contributing to society. And a big part of why I felt that way was how I was treated by the medical staff and the
Mm.
researchers.
Mm. I got to frame my illness and treatment as contributing to society. I just want to pause for a moment here. It's not just that you got to frame your illness and treatment, but that you had in the very core of your being the wisdom and desire to reframe and reconstitute a pathologized core belief that there's something wrong with you. I would like the
Absolutely.
therapists and clients out there to think about what Allie just shared. We fundamentally have the wisdom, resilience, and desire to reveal and engage our core health despite what happened to us and what we've been taught.
Mhm.
We must make this explicit. So let's unpack how this works. Allie, how did you witness language literally creating different versions of your medical reality?
So, I'd like to mention a couple of examples because I had many occasions where the way an interaction went with a doctor was paramount in making my experience positive and healing.
Mm-hmm.
But there were a few occasions where the interaction nearly led to what I would categorize as an undesirable medical outcome.
Mm.
The positive one happened at the very beginning of my first medical appointment of the whole journey. A hematology fellow was my first interaction, and he asked me a question that, when I thought about it later, really floored me. And it seemed brilliant in the way to start a long term relationship with their department.
So, what exactly did the fellow ask you in that first appointment?
So it was pretty much the very first thing he said. And he asked, "So, why don't you tell me a little bit about what you understand about why you are here?"
Hmm.
To be honest, my mother had died only days before this appointment, so I
Hmm.
barely remember most of that day. But as I got a chance to process and reflect, particularly as someone whose life is much about analyzing interaction, I realized later that the way the fellow opened the interaction was extraordinary.
Hmm. I remember when I first read the fellow's question and your response as it being transformative. This very question is actually how we begin a therapy journey with clients.
Ah, yeah.
So, what felt extraordinary to you, and it was, by the way, that's the whole point, is actually an ordinary opening to authentic relating. That it feels extraordinary speaks to a larger cultural phenomenon regarding relational literacy that we are studying and aspiring to address. The need to cultivate relational literacy and authentic relating across cultural fields, right? So
Yeah.
how did this question for you construct a different reality than typical medical interactions?
Well, most medical interactions seem to begin with closed questions or expert statements that position the doctor as the knowledge holder and the patient as a passive recipient. In my situation, however, I was being given the floor right away to report on what I understood so far about this giant medical situation. As a patient, I appreciated this approach because it gave me a lot of agency at a time that I felt literally everything was outside my control. But as a researcher of interaction and a former teacher, I realized that starting this way is also an excellent opportunity for the fellow to witness my frame of mind, to glean how much I'd understood about my brand new diagnosis, to perhaps assess a bit about things like my intelligence or my personality that might inform how he talked to me during the rest of the interaction.
Mhm.
So I saw it as such a useful way to start for both parties, making a collaborative field where I could contribute to constructing the reality of my own medical situation.
Phenomenal, just phenomenal. And how did it give you agency at that moment?
Mm. Well, the question essentially shifted me from a passive recipient to an active
Hmm.
participant.
Hmm.
It made me feel like I was a part of my medical team because I was co creating understanding with someone who had medical expertise. It honored my lived experience first, before any of the doctor's clinical knowledge was brought into the context.
Yeah, yeah. And what social dynamic did this language create between you and your care team?
I genuinely feel that it helped to create a sense of partnership in a context
Hmm.
that is far more typically one of hierarchy and power differential. The appointments where I experienced this collaborative approach, I left feeling more capable of managing my treatment, more connected to my body's wisdom, and more able to make informed decisions. I would say these conversations literally affected my capacity to heal.
That is simply brilliant. These conversations literally affected my capacity to heal. From an IRH perspective, conversation etymologically refers to how individuals are relationally constituted. That is, in conversation, we're not just speaking with, we are living and turning with the other. We are co creating reality as opposed to an expert or someone in power dictating what my reality is. The empowerment in that truth and fundamental reality must be made explicit. Yeah.
Yes, yes, absolutely.
So, you mentioned that there was an instance where you felt the language nearly led you to an undesirable outcome.
Yeah.
Can you share that situation?
Yeah. So, following the medical trial, I had a double mastectomy with reconstruction. So, that's a handful of surgeries.
Hmm.
After the one where I got my implants, I was not happy at all with what I saw in the mirror. The medical term is symastia, but I called it uniboob. So, my implants were so close together. I felt like it looked kind of ridiculous.
Hmm.
In a post op appointment, I first explained how I felt to the physician's assistant. When the surgeon came in, the PA reported to her, Allie said that she notices a little bit of symastia. What followed were the two of them speaking to each other about my body in front of
Hmm.
me. And my takeaway by the
Hmm.
end was that they really didn't see a problem. I remember walking out the door pretty unhappy and thinking, I guess this is as good as it's going to get.
Hmm.
But then, when my
Hmm.
oncologist saw my surgical results for the first time, she
Yeah.
mentioned that she thought my breasts were rather close together. That validation encouraged me to mention the issue to the surgeon right before my next scheduled surgery. While I didn't want to criticize her work, being able to say, Dr. So and so also thought they were too close together somehow made it possible for me. And I got my whole surgery changed. The issue
Mm.
was fixed, and I ended up happy with the results. So, in the end, it was a positive outcome. However, I looked back and I realized
Mhm.
how, on the one hand, just a tiny bit of interaction in that first appointment nearly led to a very negative outcome for me. But on the other hand, just a
Mm-hmm.
tiny bit of interaction in the next appointment gave me the validation I needed to advocate for myself and change the trajectory completely.
At IRH, we focus on relational health instead of mental health. What do you make of that distinction?
I think the distinction is really powerful. I've struggled for my entire life with my mental health. I was about 7 the first time I was sent to therapy. When I look back on my life, I
Mm-hmm.
now believe that a lot of what was framed as a quote mental health problem in my childhood was actually about relational disconnection. I grew up in a home where we did not communicate well, and we definitely did not talk about emotions. As a wildly sensitive and empathic kid, I always felt isolated and misunderstood. Therapy was perhaps helpful, but what I really needed was love, communication, and connection. As an adult, I've seen
Yeah.
over and over that my ability to face major challenges, whether mental health struggles, cancer, losing my parents, or even finishing my doctorate, has depended so much on the quality of my relationships. Feeling
Yeah.
surrounded by care, but especially from people with a shared experience, makes my struggle survivable in a way that isolation never does. For me, relational health is the foundation. It's what makes both healing and growth possible.
What literally impresses me so deeply is how you intuitively knew what you needed. And for the most part, what you presented was respected, recognized, and honored in your medical care.
Mm,
This is foundational for integrative relational psychotherapy. Again, how we honor and make explicit that the relationship is the medium of healing, and the paradox of that principle is that true autonomy is intimate. When a
yeah.
person's individuality is honored, the relational simply blossoms. As you say, you had both a right and a responsibility to participate in these conversations about your own health and body. I'm curious, what made you decide to start recording your appointments? And how did this change your experience as a patient?
So initially, it was just practical. I could not remember what the doctors were saying due to the stress and the medications. So a lot of people recommended it. I too would recommend this to anyone, but especially
Mm-hmm.
people who are going to their appointments alone.
Yeah.
But then, as I settled into the process of being a patient while still attending conferences and still working on my dissertation, I also began to see these recordings as a data goldmine. And I started wanting to do some type of formal research or other work with this data to really delve into how language was shaping my treatment and healing process.
Hmm. So, what did you discover when listening back about how language was shaping your experience?
Well, I have yet to go through all the recordings as a researcher. I had to
Mm-hmm.
finish my dissertation and graduate first. And these days, I'm mostly still trying to just focus on my health as much as I can outside of my job. But I
Mm-hmm.
did listen back to some of it, and there were a few incidents that really stood out where what was being said made a lasting impression on me as a patient and will be really interesting to examine further as a researcher. So I've already talked about feeling like my complaint with the reconstruction results was diminished.
Yeah.
There was another interesting thing that I thought a lot about that was said during a couple initial visits with plastic surgery. So there's this one surgical procedure that people can get where they take belly fat and they construct breasts from that.
Mm-hmm.
And to be eligible, you have to have enough belly fat. So during the part of the appointment where I was being measured to see if I was eligible, the PA let me know that I didn't have enough belly fat to do the surgery. And multiple times she told me, quote, "That's a good problem to have." On the one hand, that's framed as a problem because the medical intervention is not an option for me.
Uh-huh.
But on the other hand, it's good because what?
What?
Well, you have to extrapolate that, but the comment is basically saying that not having belly fat or being thin is preferable.
Absolutely.
I'll be honest, I felt complimented because she was saying that I wasn't overweight, which in our society is still stigmatized. As much as the feminist in me may have cringed when listening back to that,
Hmm.
in the moment, it felt as though she were constructing a genuine consolation.
Yeah.
So it was this really layered way that the professional's language shaped my experience in that case. But at the time, it worked to make me feel like at least there's some positive aspect to not being qualified for this surgical option.
Mm. Mm. My, there's so much to say about that one. And I'm just thinking about all of the mixed messages we get in culture.
Yes.
How can we not be confused about identity? How
And
can we not be confused about relational intimacy, relational literacy, authentic relating when we have all of these profoundly mixed messages
absolutely.
coming from these systems that we depend on and have such power?
Right. And the mixture of feeling like I was being complimented and yet
Yes,
feeling good about that even for 1 second made me feel like I needed to turn in my feminist card, you know.
exactly.
But when you're in the moment of, you're losing part of your body and you're facing all of that, um, it hits differently to be told, okay, but maybe this other thing looks nice on you. And yeah, it's very confusing and conflicting.
And conflicting for sure. Hopefully, actually, hopefully it's conflicting
Right.
because that means we're in awareness and we know
Absolutely.
something is, yeah, something's off, something's not aligned, something needs to be addressed.
Absolutely.
Allie, how did you balance being a patient with being a researcher? In other words, how did you navigate being both observer and observed?
Well, I guess I would say the researcher perspective never went away. And
Mm-hmm.
I think my awareness of the
Mm-hmm.
mechanics of institutional interaction actually helped me advocate for better communication. I even started telling the doctors about that fellow's question and about the importance of how they structured our interactions.
Yeah. And how did the doctors respond when you shared your expertise with them?
I probably came across as the biggest nerd ever, but I think they were intrigued.
Uh-huh.
Um, it seemed to me that most hadn't considered how their conversational choices were affecting patient experience and outcomes, at least in the way I think about it. My oncologist told me that she was going around at conferences telling other doctors about me and all the stuff I was telling her.
Yeah. Yeah. You know, I want to just take another moment here because as we were just sharing that, like how did they respond to your expertise? I'm thinking of the many people who don't have the ability or sense of empowerment to self-advocate.
Yeah, it's interesting because after my mom passed away and you reflect and you process and all this stuff, but one of the things my mom did in her many jobs, she was a big volunteer and everything. She
Mhm.
was a patient, I think back then they called it a patient representative, but maybe now it's a patient advocate. And
Yeah.
her father was a physician and her mother a nurse. And so I think I realized that perhaps subliminally or very implicitly in my young years, I also had it reinforced that, patients have rights and people need to be looking out for them. So perhaps even before all of this awareness of how that happens in interaction,
Yes.
just understanding about rights and fairness and, advocacy, perhaps that also was just sort of, I inherited some of that.
You most certainly did. You internalized that for sure.
Yes,
Yeah. You mentioned that these interactions, quote unquote, saved your life. How did specific language patterns become, I love this, healing elements?
definitely healing elements. I feel like I lucked out because not only were my doctors all highly skilled, and I got to do a trial that was extremely successful in shrinking my tumor, but I also genuinely felt emotionally supported and
Mhm.
respected most of the time by
Mm,
most of the team. When the doctors created conversational space for my understanding and agency, I think it activated something beyond medical treatment. It
mhm.
became collaboration, one that I really hope to make something out of going forward. It would be nice to have something positive come out of having cancer.
Yeah, for sure. And coming out of cancer, as you say, personally, when I hear to make something out of going forward, I think of like this podcast episode,
Hmm.
something to help others going forward,
Yes,
right? And I know that is absolutely in your heart of hearts.
absolutely.
Yeah, yeah. Okay, so let's examine the etymology here.
Yay.
Let's have some more fun with that. The word patient comes from Latin patiens, meaning suffering or enduring. It embeds passivity into the identity before dialogue begins. What would medical conversations look like if they were designed around how humans actually create meaning together?
Yeah. So piggybacking on your etymological thread, this question actually makes me think of the word binary that you brought up in our first meeting.
Yeah.
So its origin is from the Latin binarius, or consisting of two. So binary thinking, for example, reduces people to either or, doctor or patient, teacher or student. But patients hold the most knowledge about their own experience. So solutions require collaboration. That's why I prefer the notion of dialogue, which is
Hmm.
from the Greek dialogus, which means to speak across or between. So medical conversation should be about dialogue, not a unidirectional force with rigid roles, but rather a two-way exchange based on the shared creation of meaning and solutions.
Wow, we. I will say amen.
Absolutely.
So cool.
I love words.
Okay. For our listeners who want to experiment with these ideas that we are playing with today, very seriously, what are some concrete steps they can take?
Well, I think since patients usually already have a lot on their plate, I would
Mhm.
love it if the medical professionals would take the lead in this initiative. Give the patient the floor first. Let them feel like a participant in their own care because they are. Better yet, tell them this explicitly. It may feel stressful due to time management concerns, or it may slow down your typical pace, but in the end, it may lead to more positive outcomes for both of you.
Allie, you mentioned considering writing for lay audiences rather than academic journals, and that is actually my prayer, by the way. What do you hope to accomplish by making these insights accessible to everyone?
Well, just in case my dissertation advisor listens to this, I should I should clarify that I'm considering writing for lay audiences in addition to trying to publish in academic journals. But I really do feel that while we applied linguists are studying what humans do with language, How we report on it is not so accessible to most humans. If
Mm-hmm.
I'm a busy surgeon or oncologist or I'm a person dealing with cancer, I need something clear, digestible, and especially relatable. I don't know what this will look like, but I feel that there's a way to create something that will reach people more widely.
Mm. One of the IRH principles that I mentioned in my last episode with Lauren Barrigan and throughout this episode is the practice of being explicit that
Mhm.
you just mentioned. In medical conversations, we often assume and hope that understanding is shared when it may not be. Your experience showed how that fellow's explicit question created completely different possibilities than typical implicit medical encounters. Can you talk about how explicit versus remaining implicit shapes conversation analysis dynamics?
Sure. So there is just so much nuance to conversation, regardless of whether it's institutional talk, like doctor patient interaction, or everyday conversation, like at the family dinner table. In either context, there will always be parts of the meaning that are conveyed explicitly and parts that are conveyed implicitly. A lot of conversation analysis is about identifying how the participants orient to what's been said. And that's the space where you can figure out if understanding has been achieved. In the experience that I had, where I felt like the PA and the plastic surgeon were diminishing the physical problem that I had, I recognized that I did a lot of reading between the lines there. If I had spoken up in that moment and perhaps been more explicit with my dissatisfaction, perhaps things would have been sorted earlier and I wouldn't have walked away thinking I was stuck with this problem.
Mm-hmm.
But the key thing here is that I did not feel comfortable doing that, bold as I may be.
Mm-hmm.
It's not an easy thing to critique a surgeon's work, even if it's on your body. So perhaps more explicit questions on behalf of the surgeon would have helped. I understand that a question like, "Are you completely happy with the results?" may feel like it opens the door for complaints, but I think that's the point.
Yes.
In this kind of power dynamic, I don't know that patients feel the best about complaining unless that door is opened for them.
Yeah, for sure. There's something else important and related I want to explore here. The difference between being explicit and responsiveness.
Mm-hmm.
This distinction is crucial for understanding relational care. Being explicit actually operates in a kind of binary term. Something is either made explicit or remains implicit. You either state your expectations clearly or you don't.
Right,
You either make the relational frame explicit or you leave it assumed.
right.
Responsiveness, however, is more nuanced and involves layers of complexity that resist binary categorization. It includes perceptual and emotional sensitivity, what someone notices in the relational field, processing capacity, how they metabolize what they perceive, cultural frameworks, how their background shapes appropriate response patterns, emotional availability, their capacity for engagement in the moment, very much what you're talking about here,
Right.
and systemic constraints, what their context allows or inhibits, timing and pacing, when and how responses emerge, and embodied attunement, somatic responsiveness beyond verbal engagement. This suggests that while you can teach someone to be more explicit, right? State your boundaries, clarify expectations, name what you're observing. Developing responsiveness requires addressing multiple interconnected factors
It
simultaneously.
does. Yeah.
Someone might master explicit communication, but still struggle with responsiveness due to overwhelm, cultural misalignment, or compromised nervous system capacity.
Yeah.
So, what can CA capture about explicit moves versus these more complex dimensions of responsiveness? That's a big one right there, but it's really beautiful. And and important. It really matters.
Yes, it really does. I have a friend who's an ER psychiatrist and also a professor of medicine. So he works with and trains doctors.
Yeah.
I brought my idea up to him of in some way using both my analytical mind and my cancer survivor mind to help change some of the ways that medical professionals interact with patients. And he made a similar point. Sure, you can teach med students some of these explicit practices that they could essentially memorize and execute, but it won't make up for the inherent ability that some people have, but some people lack to naturally engage and be responsive. So
Mm-hmm.
it's a fair point.
Mm-hmm.
But, I suspect that any medical professionals who are not yet great at being responsive in interaction could really benefit from at least becoming aware of how their approach influences the conversation. In my field, we use video recording as a training tool in education. And this is so that novice teachers can not only get a more objective sense of what they're doing while they're teaching, but they can also see how their students are responding. We also have in CA what's called CA-based interventions. This is when the practitioner, say a doctor or a teacher, for example, gets recorded while practicing. And they may also be trained a little bit in CA transcription and analysis. And there's evidence that participating in this kind of research can really open someone's eyes about their own interactional practices and patterns. And there's also longitudinal work that shows it can help them change over time.
Mm.
So I really think that there's something there that could be
Mm-hmm.
adapted to, at the very least, help people start to see what responsiveness looks like,
Yeah.
what happens when it's missing, and so
Yeah.
on.
Yeah. What's so cool for me is that what you are describing is what I would actually call therapeutic. It's not therapy,
Hmm.
it's therapeutic
Makes
because
sense.
of what we're creating in the relational field.
And part of that is the relationship with yourself, right? Like, I think
Absolutely.
when you're a practitioner, I mean,
Mm-hmm.
they've done all sorts of studies about this, but, you
Yeah.
know, we think we remember what we did when we taught or when we think we remember. But our memory isn't perfect ever, and it's always subjective. And so having a video recording for you to be able to see yourself doing
Yes.
whatever it is that you do,
Yes.
I like to think it creates a little person that stands on your shoulder so that if you're a teacher who talks too much or, your volume's too low or anything,
Mm-hmm.
then you get this little other person that can kind of objectively remind
Yeah.
you, oh, there's that thing that you do again.
It's like the meta witness.
Yes. Yeah. And with technology, like, we didn't have this in the past, but now we
Right.
do. And I
Right.
think that technology can help us
Mhm.
the recording at least can help us become more objective.
Yeah. Yeah. And this is great because technology can become more relational.
Yes. It's not going to go away. So I think,
I believe that to be true.
yeah.
Yeah. So what message do you want to leave listeners about the power of language in their own healing and growth?
Okay, so I'll start with a little poem that I recently found in one of my childhood notebooks when I moved. There I wrote, "Sticks and stones may break my bones, but words, they can destroy me." So can you
Mm.
tell I was bullied as a kid?
Mm.
But seriously, I think I've always understood the power of language. My little poem is obviously reacting to how language can hurt people. But as an adult, I've also had the opportunity to see how language can be crucial in healing as well, from cancer, from trauma, from isolation. So I want to highlight for people that interaction is not a secondary part of any situation, especially in medical interactions. For patients, I would emphasize that your voice is paramount, even if you're not a medical professional. Try to speak up. Write questions down in advance, especially if you struggle to be explicit. You are an agent in your own healing, and a big part of this comes from making yourself heard. For the medical professionals, start by listening, please. Even though it may even though it may feel like you're pressured to make an appointment swift and efficient, framing your work with a patient as more of a partnership and less like a binary hierarchy can make those in your care feel like they have agency and some semblance of control, which can make
Mm,
tough journeys easier and healing more positive.
mm. Yeah. There are two things that you and I share. This we've always had this sense of the power of language. And so I was also wildly sensitive.
Mhm. I
I
think when
love
you're sensitive, you can't help but because you get so impacted and then you digest it and you obsess over it sometimes. But
Yeah.
yeah,
Yeah. So, Allie, I want to thank you um, for sharing both your expertise and your very personal experience.
of course.
Um, I honor the tremendous courage it takes to transform your own trauma, our own trauma, into a way of helping others navigate their own challenging moments. This reveals something about consciousness development that goes beyond individual insight. In our transdisciplinary approach, we recognize that conversations don't happen between separate individuals, but emerge from living dynamics between people.
Mm.
Your work demonstrates how rigorous attention to conversational dynamics can reveal the relational foundations of healing itself. Um, where can our listeners learn more about you and your work?
So for now, you can find all of my publications on Google Scholar. I think I'm the only Allie Hope King there. Um, but I would also like to highlight a research group that I'm a part of here at Teachers College called Lancy. So we hold monthly data sessions online that anyone can join. You don't have to have experience in the field at all.
Mm-hmm.
And we also have an annual conference in the fall where researchers from all kinds of backgrounds come and share work that examines interaction.
Mm.
So you should check us out. It's really the conference. It's a small boutique conference that meets all in one room. So you get to hear all of the papers and interact with everyone. It's the best. I mean, I have to say it's the best, but it really
Good.
is.
Yes. All right. I invite all listeners to reflect on your own communication experiences. And I'm sure Allie will agree with me here, right?
Hmm.
Whether in a healthcare setting or some other high stakes conversation you may be having in your life right now. How are you advocating for yourself? What
Mm.
tools can you use to help you be an active agent in your own care? For viewers, some action, well, I'm sorry, there are no viewers here.
Listeners.
Okay, here are some action steps this week. Notice empowering versus diminishing language. Pay attention to whether your conversations create space for collaboration or reinforce hierarchy.
Mm.
Practice genuine curiosity. Start one conversation this week with curiosity about the other person's understanding rather than immediately sharing your expertise. Consider recording important conversations, right?
Hmm.
When appropriate and with permission, record crucial conversations to better understand the dynamics at play. A great exercise for couples, by the way.
Oh, yeah.
Right?
Yeah.
Subscribe and share. If this exploration resonates, subscribe to Etymologies of Care and share with someone who might benefit. Remember, every conversation is an opportunity to practice the kind of language awareness that supports both individual flourishing and collective consciousness development. Thank you all for continuing this inquiry. Until next time, this is Etymologies of Care. Thank you for joining me for Etymologies of Care. If today's conversation resonates, I invite you to share it and keep the dialogue alive in your own community. You can find resources, learn more about relational health, and connect with us at integrativerelationalhealth.com. Until next time, may you care for yourself and others